Hello everyone and welcome to our module on somatic disorders. Somatization means physical symptoms without evidence of underlying organic disease. And when we talk about somatization in psychiatry, we usually mean the physical expression of stress or emotions. So many of us, when we are stressed or depressed or anxious, will develop physical symptoms like headache or bellyache or backache. These symptoms are not due to some underlying organic problem, they are related to our underlying psychiatric state. So an important element of somatization is symptoms that are not explained by medical disease. Importantly, patients with somatization are not consciously creating their symptoms for gain. When that happens, it's called factitious, and we'll talk about that later in this video. And many patients who develop somatization type symptoms have underlying anxiety or depression. The list of symptoms that can result from somatization disorders is enormous, but I've listed some of the important ones here. So many patients with somatization present with pain symptoms like headache and back pain or joint pain. GI symptoms are also very common, things like nausea, abdominal pain, bloating, or gas. In my field of cardiology, I see a lot of patients who have somatization with chest pain, dizziness, or palpitations. Neurologic symptoms are also very common. Patients sometimes report fainting from somatization, also things like muscle weakness or blurred vision. And then symptoms like dyspareunia, which is painful intercourse, or dysmenorrhea, which is painful menstrual periods, are also common with somatization. Shown on this slide are some of the elements of management of patients with somatization. First of all, you always want to avoid debating whether the symptoms are psychiatric or medical, and you don't want to challenge the patient if they have a belief that the symptoms are definitely caused by underlying organic disease. Regular visits with the same physician is always recommended, and it's high yield to know this for your boards. By having them see the same physician every time, that person will get to know them and the patient becomes more comfortable. It's also less likely that unnecessary tests will get reordered if they see the same doctor every time. Along those same lines, in general, you want to limit ordering tests and referring to other providers. And then you want to reassure the patient about all the things you've done to rule out serious disease. In my own practice, I spend a lot of time doing this with patients who have somatization. You want to remind them that you've listened to their heart and lungs and everything is normal, that their blood pressure is normal. You want to review any tests you've done that have been normal. These things help to remind them that they have an overall healthy body and that they are at low risk for a life-threatening disorder. You want to set goals of functional improvement, not a complete elimination of symptoms, because that may be difficult to achieve. Any psychiatric issues need to be addressed gently, and as I mentioned earlier, psychotherapy is very effective for somatization, and if you can get the patient into psychotherapy, that often helps. So any patient can have a somatic symptom now and again, but if they have recurrent and persistent somatic symptoms, then they can meet the DSM-5 diagnostic criteria for a somatic symptom disorder. To meet criteria, patients have to have somatic symptoms that cause distress with persistent thoughts about the seriousness of the symptoms, meaning they are worried that they have a life-threatening or dangerous underlying organic medical disorder. The thoughts have to cause anxiety about the symptoms, and they have to devote excessive time and energy to thinking about the symptoms, and then they have to be persistent, usually for at least 6 months. Moving on, let's talk about conversion disorder. This is also known as functional neurologic symptom disorder. Conversion disorder usually has a sudden onset following a stressful life event. It could be the death of a loved one, it could be a breakup of a relationship, but something that is very stressful to the patient. The symptoms they will develop will be neurologic. They're either sensory symptoms or voluntary motor symptoms. So it could be the inability to speak or move. The patient could also report blindness or even have seizure activity. The neurologic workup will be entirely normal, and the patient's positive findings are often incompatible with disease. For example, a patient may be unable to plantar flex their foot, but they can stand on toes. Obviously, if they can't plantar flex, they shouldn't be able to stand on their toes, but they can, and that's a sign of a conversion disorder, not an organic disorder. Many patients also have what's known as labile indifference. This refers to the patient showing a lack of concern, meaning indifference about the symptoms. So in a board question, this will be someone who had a very stressful life event and now develops some motor or sensory symptom. The workup is entirely normal, and the patient seems unconcerned about the neurologic symptoms. Illness anxiety disorder is another DSM-5 diagnosis. Patients with this condition have a preoccupation with having an undiagnosed illness. They usually don't have a lot of symptoms. They may have very mild symptoms or no symptoms at all, but they are worried that some illness is lurking in their body that has not been diagnosed. This causes them to have anxiety about their health, and they often engage in a lot of excessive health-related behaviors where they are repeatedly checking for signs of illness. This could be things like checking their temperature or recording their blood pressure, and symptoms have to be present for at least 6 months to meet the DSM-5 criteria. In somatic symptom disorder and conversion disorder and illness anxiety disorder, the patient is not purposely making something up to draw attention to themselves. But now we're going to talk about factitious disorders, and in these disorders the patient is purposely creating a false symptom or false sign in order to draw attention to themselves. First disorder we'll talk about is factitious disorder on self. This is also called Munchausen syndrome. In this disorder, patients falsify medical or psychiatric symptoms consciously out of a desire for attention. Some patients will feign illness, meaning they will make up a symptom. Other patients have a genuine illness, but they aggravate it on purpose to draw attention to themselves. And patients with this disorder are often willing to go for tests or even surgeries because they really value the attention that they get from playing the sick role. Patients engage in the factitious disorder on self for primary gain. This means an internal gain, something internal to the patient. They feel better in the sick role, or the sick role resolves some type of conflict that they have. For example, if a patient is afraid of work, or if a patient is afraid to be alone, they may develop a factitious disorder because this gives them attention and lets them get out of work. But the key thing here is it's done for internal gain, for making them feel better. It's a chronic persistent disorder. Risk factors are female gender, being unmarried, and a prior or current healthcare worker like this guy on the screen. I saw one case of this when I was in training. It was a woman who worked in the microbiology lab, and she was purposely injecting bacteria into her bloodstream to cause bacteremia. Obviously, this was a woman who was very sick and needed psychological help. Factitious disorder on another is also called Munchausen by proxy. In this condition, someone falsifies medical symptoms as a caregiver and falsifies symptoms on the person they are taking care of. So this could be a child, this could also be an elderly person, but the person with the disorder is making another person sick, either making it up or purposely making them sick, in order to draw attention to themselves as the caregiver. I'll finish with one slide on malingering, which can be confused with Munchausen syndrome. In malingering, a person consciously falsifies medical symptoms, but they do it for secondary external gain. For example, by falsifying symptoms, this might allow the patient to miss work but still get paid, or it might allow the patient to obtain workman's compensation. This is not considered a DSM-5 psychiatric disorder, and it's usually a self-limited condition. It ends when the secondary gain is achieved. So for your board exams, you want to be able to distinguish malingering from factitious disorder on self. A person with malingering is trying to get some type of secondary gain. It's usually to obtain money. A person with factitious disorder is trying to get internal gain. They are trying to make themselves feel better by assuming the sick role. And that concludes our module on somatic disorders.